my understanding of today is just to do kind of a simple overview of our intellectual properties, or the software that I would really describe as the tool set that we use to do the job, that kind of the task at hand. So I'll start by just kind of framing up, really for the call, but also as a review for all of us, kind of what the purpose that we set out to accomplish, kind of what problem we're solving, and kind of philosophically where that's originating, what our business model is in very short today. And then I have both Sadie, our Director of Operations, and Eric, our Director of Information Services, to kind of help me navigate some pieces that, candidly, I'm far less familiar with some of the operational and technical pieces of our tool set than they are, and they'll help us through that. So at a very high level, just to kick it off, as a reminder, we're currently in a service provider role in the business of going into existing practices, more specifically primary care practices today, going in and identifying where health improvement opportunities are, going in and identifying where revenue-enhancing service opportunities are, and helping that practice perform in the new world of accountable care or population health management, helping them perform at a higher level, and doing so with a proven business model, not just investing more resources to take better care of people, but investing more resources to take better care of people in a business model that makes great sense for the practice itself. And I think we've substantiated that now across, a couple hundred practices and several hundred PCPs in multiple states and so on. So to dig in just a little bit, most of our users, and I'll also frame up, mind you, most of our users really are internal, whether they're a position that we call a care team coordinator, whether that care team coordinator is centralized in our call center or an embedded person within the practice, whether that's somebody that we employ or somebody that the practice employs. It really is a set of responsibilities that the user would follow the software in kind of a, I don't know, for lack of a better term, kind of a paint-by-numbers plan, that if they just follow the steps, it produces a compliant outcome. And I've asked Eric to really help us put, quote-unquote, kind of bumpers on the bowling alley that keep the users from throwing the gutter balls, that they can't do an annual wellness visit not in compliance, or they can't do provide the services not in compliance. Really, the software kind of keeps their effort and attention navigated down a compliant path to produce a very user-friendly, compliant, revenue-generating service for the practice and health improvement for the patient as well. So with that being said, just kind of the strategic direction as a little bit of a preview for what we'll probably end the call with is we have a tool set right now that's proven and functional, and now we have an opportunity to advance the portal in kind of twofold. One, to be an internal proprietary piece of software that we apply to our own owner-operated practice model. I think that's kind of a given. But two, kind of the advanced opportunity with some of the ACO or IPA, maybe even large health system stuff out there, to incorporate a physician ancillary revenue or in layman's terms, other services that could or should be applied with evidence-based medicine, following evidence-based guidelines that should be applied, identified by the software. So where a service opportunity is identified, a patient with a specific age, gender, reported condition, evidence-based guideline gap in care, that this algorithm produces a recommendation of service. This patient's been to the emergency room 4 times for, sinus rhinitis. So this person's there's an allergy test recommendation there. Or this person has been to the emergency room, 9 times for migraine-related symptoms, and they've done a head scan, and it's for sure not a brain tumor. There's an adverse drug reaction going on. Well, maybe it's evidence-based guideline recommends pharmacogenomics or genetic testing to identify how that individual person metabolizes that. So with that kind of as a philosophical foundation laid kind of for where our tool set is and then where it's going, I'm sure you're interested to look at the actual applications. So most of our users, if you see right here, the member login of our main homepage, most of our users would go there to access the portal and the activities. We built this demo portal that doesn't have live patient data or at least scrambled or de-identified data. And you'll see kind of our ITAR 5, the philosophical path that we're trying to accomplish is identifying, tracking, attacking, and reporting gaps in care. So we are proactively helping practices identify patient opportunities, track those patients through the system and through their health improvement progression, care management strategies to attack those gaps in care. How are we going to operationalize and proactively attack those? How are we going to prioritize those? And all that's kind of handled under the care management portal. And then the reporting, so telling the insurance providers, whether that be Medicare or Blue Cross, here is our quality improvement, here's our gaps in care, here's our diabetics, and here's the diabetic foot exams that we've accomplished. The national standards are at 42%, and here we are at 68% completed. So those type of examples. At the bottom, you'll see here where we have a launch application as well as launch the presentation. So if a user is interested in, specifically, I'll just pull up the quality reporting because I know we'll use that. So it'll specifically go to kind of what is the portal's function and then kind of how does it work, kind of a walkthrough for them before they launch that application. So while we go through some amount of training, whether it's an internal care coordinator position or embedded care coordinator position, there's always kind of the resources for them to go back and understand the purpose of the portal and how to use it. So let me just start with a POP Health Management. So from here, they have an opportunity to go down the dashboard, to click on an action portal for their specific patients, or download the data. And I would say that the 3 use cases here is most of the users would go right to an action portal and go to work. A POP Health Management would be something for the executive management team to log in once every so often and look at their provider scorecard. And then download data is really for the IT side or for the, we call it the 1 in a million physician nerds that want the data and think that they can, find something or solve something, that they just want that information to look at it and analyze it and come up with their own deductive reasoning. That's available for them.
Do you de-identify that data before you download it?
Do we de-identify the data before we download it? What do you mean by that?
Yeah, like you just gave them an opportunity to download the data to do kind of research or something with it. Is that like a large data group?
No, let me get to that as the third piece, and we'll click on reports, and I'll show you the practical reports. But it would be, for Dr. Jones in, Damascus, Arkansas, it would show specifically Dr. Jones, his or her patients, and the health factors that are going on with his or her specific patients. So they can look at who their top 25 spend is. They can look at who their ER utilizers are. They can look at who their diabetic patients are and what quality metrics are satisfied or still missing. So it kind of gives them detail level data on their specific patient population. They don't have access to somebody else's patients.
Yeah, well, I didn't think so, but I didn't know if I just got thinking about that when you brought that up. Sorry, didn't mean to sidetrack there.
All good.
No, it's okay. We do download data. It's all HIPAA compliant as far as the SSL certificates and things of that nature. And and really, if you got into it like an EMR or a health reporting tool, they all kind of do the same thing. You can download CSVs and Excel files of patient data all day long, as long as you are authorized to do so.
Perfect. So this is just what we call just a snapshot or a dashboard. It shows the big 5 key performance indicators and the next 5 wow. So the wow is kind of the worst of the worst. We ask, providers to really focus on the big 5 tiles. Those tiles are customizable. If we set a different goal and objective for a specific provider or specific practice or an IPA in Tennessee, for an example, and they said, hey, we really want to focus on these 5 KPIs, we would just build a tile specific to those KPIs. So you can go into report settings, and you can say, hey, I want to look at a different organization. I want to look at this particular ACO, and I want to say, Arkansas SQHCs, for example, and let's look at, 2 different providers, and we'll say, a Frank Rector that isn't doing so well. His overall cumulative grade is an F. A lot of frequent flyers in the emergency room and hospital, and then you can go back and say, well, what's a different provider? How are they performing? A little more towards the satisfactory improvement on the cost and quality, which are big indicators, as well as the utilization, while they improve in kind of the areas of wellness visit and chronic care management. They can also go to the action portal that I had addressed earlier, and this is de-identified here. It would be identifiable data to say these patients are attributed to these providers. Here's the patient, their insurance type, and then what's the alert? Well, the alert is here. It's hierarchically sorted and prioritized that these are patients that have 2 or more inpatient days of service. So they've been hospitalized 2 or more times with no PCP encounters. So we know there's a really high likelihood that this patient's going to go back to the hospital without some PCP intervention. So what's the task? We want to call that patient and engage them back with the PCP. Or this patient's had multiple ER encounters. This patient's in the top 25 of spend and has multiple gaps in care and hadn't had a PCP encounter in 4 months. So those are kind of what the action portal is, and then you can say patient refused or already done, awaiting response, and you go down here and you can say I left a voicemail, or patients in the nursing home, already done, patient refused, do not call, fired or deceased patient, things of that nature, kind of within the action portal. And then to go to the downloadable data, here you can, just as an example, you can come across and you can say, here's the patient detail, and then as it scrolls across, you can see, what are the, unless you're an ACO, you probably wouldn't understand it, but the benchmark data, what are the benchmarks on these patients based on a 3-year history, and then what are the indicators of spend trend moving forward, some identifiers here under whether or not that patient's identified as a diabetic, yes or no, and then specifically whether or not you can identify that it's completed. If you see one of these like completed CCLF, we can see that is completed, and then what's the source of that completed data? Well, that's identified through CMS claims line feed. So CMS claims identifies that is completed. You could also find it completed under EMR or missing or unknown. And then you can kind of go through the same process here with pneumonia vaccinations or end-stage renal disease or COPD, congestive heart failure, etc. And then under those diagnoses is the same process of whether or not those specific quality metrics are completed or not. So this is just a very data-heavy example of the action report here. Kind of does the same thing as before. It's a manageable report that could be printed for somebody if they didn't want to use the software. Say these are the actions that are needed. This is a custom report that we did an analysis a couple years ago on a large group that had about 80 doctors, but in that very low attribution through most of the specialists. So we could really identify where our resources needed to be dedicated on the providers that had the critical mass. I think you can see right here that we had identified 4 of the locations that held 83% of their attributed patients. So we didn't need to distribute resources to we didn't need to distribute resources or a care team coordinator at all 7 locations. We could really focus on, or all 16 locations, we could really focus on the 4 that had the vast majority, and then get some coverage of a care coordinator out to the other couple locations to cover 96% of their attribution. Kind of the same thing here. 22% of the providers had 90% of the attributed patients. So kind of where we could attribute resources, kind of a strategic look for the practice of identifying, who hires those care coordinators, whether it's us or them is to be determined, but really kind of a strategic look on where you get the most bang for the buck to place somebody to do those key activities. And then from as a foundational service, and I'll turn it over to Sadie here, but as a foundational service, we see a comprehensive risk assessment or quote-unquote annual wellness visit as a foundational service that's strategically critical to proactive population health management. You need to be able to identify what the true risk factors are of an individual patient, which candidly change year over year, but to be able to identify those risk factors and proactively manage those risk factors is important. So we built a portal based on age, gender, insurance type, and reported conditions to load the appropriate assessment, complete that assessment in a time-efficient, user-friendly way, and in full compliance that generates the visit summary as well as the 5-year preventative care plan at the end of it, based on the evidence-based guidelines.
So this is actually the view that the care team coordinator or the nurse would see when they log in. This specific one is going to be for the Medicare annual wellness visit, and it would identify it at the top to show what assessment type you are doing for that current patient. The patient information is going to be the first tab that opens. That information is actually populated from data that's collected from the clinic's reporting system. So all that's pre-populated. The nurse would go through and they would confirm or add in any additional information that the patient would have upon the time of visit. Each section is very user-friendly. The nurse would be able to navigate through the entire assessment one by one, be able to have the green check marks to show that particular section was completed, or they would be able to skip around and add information as the assessment was completed. We are going to touch on just a few of these just to show the pop-ups and what the aftermath on the risk assessment would show for them.
So each of these assessments would take, 20 to 25 minutes. I don't think we need to walk through every decision tree of every section, but do want to show you kind of the philosophy of the Q&A and the pop-up logic that's in there, and then ultimately get to a visit summary and care plan.
So we will go to reported conditions. This is actually the section that lists the patient's reported medical conditions. It's also the section that triggers the patient for the CCM program, or what we specifically call internally, and when we're speaking to the patient, the VIP program. So here we are going to put yes that the patient does have current medical conditions, and then when we click through these, we will actually have a pop-up after
2 or more, right?
2 or more chronic conditions. From here, we have the opportunity to be able to print off the VIP sheet. This can be given to the patient. It is also basically a navigation tool for the nurse to be able to explain to the patient what exactly is the CCM program and what to expect. So when they do that initial outbound call to the patient will be very familiar with why the nurse is calling them, and they can even refer back to this template to let them know, hey, I gave you a form when you came in. Do you remember that? Kind of recall their memory for that initial call to get them set up for those. So we're going to hit yes here. When we hit yes, it will actually pull that patient over into the CCM portal automatically and will trigger that for the initial call. So technically, after the AWV assessment is completed, the nurse could turn around either the same week, following week, or even wait till the following month to reach out to that patient. And anybody that is triggered for CCM will automatically appear in that portal. The next section that we're going to review is the medications for the medication reconciliation. So here we would put yes, and then you're given an opportunity to reconcile the medication in the EMR to determine if the patient is taking all of their medication that's prescribed, if they're taking it as prescribed, or if there's any additional medication that's been given to the patient by either specialists, ER visits, things of that nature.
So both Dan and Ron, especially for you, Ron, something that we have found is while we desire to capture the data here within our AWV assessment, we have had multiple clients come back and say, no, we like the whole assessment. We just really want the medications reconciled and updated in our EMR. So to avoid the duplication of work, but also to quote-unquote check the compliant box, we can check reconcile RX and EMR here, and it documents that it was reconciled in the EMR, and that work can actually be done in the EMR, which satisfies the desire of our customers, if that makes good sense. You can go ahead and go on.
Okay.
Yeah, it does.
Not necessarily our preference, not how we would necessarily want to do it within our own practices, but that was a constant theme that we ran into with several of the last customers that were implemented, is they all kind of kept coming back to that same, hey, for XYZ purposes, we really want this done in our EMR. And we had kind of gone back to the drawing board and said, well, we really need to document that it got done here for compliance. So we'll just put up basically a checkbox to say if they want it done in the EMR, we'll check that it was done in the EMR. But also it will put on this visit summary that was done in the EMR.
So does this, I was just wondering real quick, on this process of doing this assessment, because we talked a little bit before about trying to get the administrators there to do the work. Is this something that they kind of push back on when they look at using the system, or is it something they're already doing?
The administrators, I would say probably not. I mean, it's pretty receptive all the way around. Nurses like it much better than the templates that are currently in the EMRs because it's more time efficient. They're able to do these assessments in, we'll say, 15 to 30 minutes. I have some nurses that can do it in about 12 to 15 minutes, but it's more of an efficiency thing for the nurses. They're able to upload this template, the risk assessment that's done at the end that's generated. They can actually load that as a PDF and attach it to each encounter and bill right off of that instead of having to input each and every aspect of it. So it's just more efficient, so all around more receptive in my.
Yeah, and to add to that a little bit, I think two other perspectives would be, I think the feedback we get is the physicians appreciate that it's done this way from a, for lack of a better term, kind of a CYA perspective, that they say, hey, for me to do a compliant, quote-unquote, care plan based on age, gender, and reported conditions, I have to spend, 20 to 40 minutes handwriting or typing out all the specific pieces of a long-term preventative care plan. When they hit the age of X, they need these testing or these screening services, male over the age of X, prostate exam, female over the age of Y, mammograms every X amount of time interval, all of these things that we've kind of programmed the logic that at the summary of this, you click, complete, and it auto-generates a compliant report based on all the evidence-based guidelines if they check diabetes, all the evidence-based guidelines if they checked congestive heart failure, all the evidence-based guidelines if it's a male over the age of X or Y, a female over the age of Y. And it also does the same thing for children. For kids under the age of X, it talks about, choking hazard and child restraint and things of that nature, developmental recommendations, assessments, parts of their care plan that happens, beyond the exam room walls. So that's kind of the perspective of the physician. I think the administrators appreciate the compliance, and by administrators, I'm talking about kind of the owner-operator management team, if you will, being the administrators of the practice. They appreciate it from a compliance perspective that, you know, hey, as a manager responsible for this clinic's compliance, I really don't know if every nurse or every doctor is doing everything within compliance at every visit, but I do know if they completed in the software, then they kind of quote-unquote had to. They kind of had to do it within compliance, or it wouldn't let them complete it. And then from a user perspective of the care coordinator, I think they appreciate it from a user-friendly perspective. They can blitz through it. There's a decision tree that if it says no reported conditions, you don't have to go on and ask the next 11 questions. If there's no reported conditions in the EMR and the patient says, no, I don't have any, conditions or issues, then it completely skips that and goes right under, depression screening or right to, the next appropriate section. So that's our thoughts on kind of the different perspectives of the benefit that it brings. Go ahead.
Okay. The next aspect that we're going to view very quickly is going to be functionality and safety. A compliance metric would be the fall risk assessment, and that's exactly what this section is. So I asked a series of questions to the patient to complete the fall risk. The next is going to be the mental health portion. This section is another metric that has to be done in order to be compliant, which is the mini mental health section. If they answer 3 of these questions and they fail them, it will trigger on the risk assessment for the provider to review with the patient and decide if additional treatment is needed at that point. The next section we're going to discuss is going to be the depression screening. This section is important because it decides if the patient is depressed, if they are suicidal. If they are suicidal, it will trigger immediately a severe risk for the provider to step in at that point and go over that with the patient, see if there's anything additional they can provide the patient in that visit specifically. If there's no high risk, if the patient's on medication or they've already been seen by the provider for suicidal ideation, then they can continue on with the assessment and bill it as is. If there is additional provider time needed for it, they are able to bill it with a modifier for additional reimbursements.
So here, as Sadie was talking, I had clicked, that they have some feeling of loneliness or sadness or depression, don't experience any abuse, haven't had any thoughts of hurting themselves or ending their life. The nurse concern, I put medium. There was a question that popped up. I don't know if you saw it. It asked, have you discussed depression or treated for depression by your PCP? And I had said no. So this right here is a mock-up that Eric and I have recently worked on at the request of a potential client that's saying, hey, we could really blow this out under a behavioral health integration, but we don't have a tool to do that. We have the people and the skill set to execute this. We've even got the clients wanting to come on board with this, but we don't have the tool set to be able to do that. What would that look like for you guys to do it? And we had looked at it internally and said, hey, this is almost a perfect replication of our chronic care management portal. So this is kind of what that would look like. When somebody's identified as a candidate, it basically asks, do you want to enroll that patient into that service? So Sadie had said earlier, kind of under chronic care management, if somebody's identified with 2 or more chronic conditions, it automatically puts them into the CCM portal, so they're on the CCM roster. So kind of same thing here. As depression indicators are identified, it puts them under a behavioral health management portal. This is the roster for the behavioral health integration service once they're enrolled. You could open a specific patient. You could click to call. You could engage that patient, see what their chronic conditions are. You would also walk right through their specific sections. This is a live piece of software under CCM. This is just taking it as a mock-up and applying it to the BHI, which they were really satisfied and impressed with. Under each section would be kind of the questions to finish the assessment, and then it would be a behavioral health visit summary or risk report. You know, they went through the service and there wasn't any indications, and the recommendation is for a follow-up in 1 to 3 months. And then this is the kind of specific risk report if any specific areas that were discussed with the patient were identified and triggered any risk. So it's just a quick example of, you know, how we would use the annual wellness visit or the comprehensive health risk assessment as a tool to trigger other services. So right there, we could add that patient directly to the BHI service, and here we would say, minor I can't even see it. Depression here. Identifiers. Far away. Enrolled in BHI. So when you save that, it puts that directly on the report for the provider to review at the next encounter. Physical activity, that's an area of compliance. You can put any notes there, and then goes right into, this is PAR. Ron, I don't know if you can see it. It's kind of small on my screen right now. But the PAR right here, the physician ancillary revenue, kind of falls in line with the integrated testing services. And these are just sample questions for this section as a mock-up that says, does the patient indicate that they have 4 or more medications? If yes, obviously you're aware that would trigger a pharmacogenomics test. Have they been genetic testing last year? And I asked Eric to put no and then indicate that a no will trigger that for an evidence-based guideline recommendation. Do they have any cardiovasculars? Well, that may, be a decision tree to qualify them for a blood wellness test. Is the patient over 50 and have any adverse family history of colon cancer or, to trigger a colonoscopy? Yes, they are. Have they had a colonoscopy in the last 12 months? If no, they have not, then that's an evidence-based guideline. And then a couple placeholders. This section is fully customizable and incomplete based on an individual practice's preferences. But, if question, is this patient XYZ, yes or no, and then one of those will trigger for a service.
Hey, Nick, and let me just say to Dan, the reason this is important is that testing is one of the areas in medicine that has historically been ripe with fraud. There's significant amount of over-testing done by unscrupulous physicians, unknowingly sometimes. What we're trying to do, let me back up. Because there is so much fraud in testing, many physicians avoid doing tests because they don't want to be guilty of over-testing. The value of what this does, it provides the physician with reassurance that they're only testing patients who meet the criteria that the insurance company has put forth that says it is medically necessary to test this patient. So with this particular module in the software, physicians can be well informed related to what tests they should be ordering, knowing that they're doing it in accordance with what the payers have said. These are how we define medically necessary tests.
Okay, no, that makes sense.
Right. So just to give you a quick glance here, this is some sort of a decision tree or a truth table that basically says, that they may be eligible for a blood wellness or advanced lipid if they meet these criteria. This is the evidence-based guideline recommendation. Or, if there's diabetic retinopathy, this is the trigger, and then this is the action. So we can go through and say, if X, then Y, based on the different services to qualify a patient's eligibility based on medical necessity and then we can say this particular patient, Mary Poppins with these conditions, she qualifies for these services, and under these services, these are the ones that are completed and these are the ones that are outstanding or missing for consideration. So you can go, basically truth table to a roster which shows what services patients are eligible for. You're able to open that record and then go to the patient record to engage that patient to provide those services, whether they're in the exam room at the time to get them to the care team coordinator or collector, depending on the ancillary test. It could be a lab test or a collection needed, or it's at patient's home and we're just running a query of which patients qualify for allergy testing and immunotherapy. Then we could, run a query or run a report on who qualifies for that, and then pull up the roster of, who qualifies and telephonically engage them. So I think that's just a small a small add-on, I should say, to what we call our normal assessment doesn't include this piece, but we've mocked this up just to give, us an example of what that would look like to add on the ancillary revenue piece. So I would say, here at the final, I would say mostly low risk, moderate concern for depression. And that's just a care coordinator has an opportunity to add comments to every assessment. Obviously there's some black and white pieces of compliance, but then there's also the opportunity for them to add indications that they picked up on. So you can see, right there at the top is the risk level that was identified. Patient has not discussed stress and depression with the PCP. There are their conditions. It would say, that this was entered into the EMR, and then of all the sections that were walked through with that patient, it'll show just a couple areas that trigger. And that's what we really want to train the physicians on, is encourage them. They don't have to read every comment in every section of every color code. Just focus on the areas of risk. The orange is the medium risk. The red is the high risk. Focus on the red and orange of every report and just use that in your follow-up discussion with the patient. So that is scanned directly into the EMR, and an alert is put that next time that patient's in front of the PCP, it says new document available in an alert, and they open that document and discuss that document with the patient. And then this is the age, gender, kind of reported condition, standards of care. If the patient is X, then Y. And this kind of walks through their specific things for diabetes, what are the standards of care for diabetes, and then for heart failure. And then you'll see in the next portal of chronic care management how those specific evidence-based guidelines are verified as completed or incomplete. I'll let Sadie walk through this. You can see the ZZ Test Clinic there on the left. Go ahead.
So when the care team coordinator logs in, they'll have a list of whatever clinics they're assigned to or whatever group of clinics they're assigned to in order to do their outbound calls for chronic care management. Here you're going to see the roster that they would see. It is sorted by last attempt. It's sorted by action needed, either initial call, second attempt, third attempt, etc. So from here, we would launch the assessment. And then on the left-hand side, you're going to be able to see the current conditions of the patient. We train the nurses to have the EMR or HR pulled up as well. That way they can kind of confirm everything is in their system, that they've updated all current conditions that the patient has. It also allows them to get an overview of the patient based upon their demographics to ensure, number one, that they're talking to the correct patient, and number two, that they gather the information needed for the call. You can expand the information. You can see that the address, things like that. Sometimes there's patients that have the exact same name, so that helps identify who you're speaking to. We do have the internal click-to-call system, so the phone numbers are actually behind these buttons. You're able to click on them, and it automatically calls the patient for efficiency purposes. And then once they encounter the patient, either it's a no answer, it's a callback, it's a bad number. If it's a bad number, we're able to look into the EMR to see if there's any additional phone numbers listed that the data did not pull over to the system. If you are able to reach the patient during this encounter, then you would be able to start the CCM assessment from there. It shows over here the buttons, the open buttons, the red ones are the ones that do need either edited information, updated information, it needs something completed in there. The ones that have the partial orange buttons are stating that it does have information in there from the AWV, however, there could be updated information needed from the patient. For instance, if the patient was not depressed during the initial AWV encounter, then from here that would be a question that we would want to ask. You know, overall, how are you feeling today? Are you depressed? Are you feeling lonely? Things like that. We can actually get those triggers, if there are any, to the provider and get them in for a follow-up visit more promptly than their initial AWV would have considered. So from here, there is a section, evidence-based guidelines and standards of care.
Yes, this is kind of what I was talking about earlier of through chronic care management, kind of our belief structure and conversations with Medicare is that it really is a risk management tool, mostly on kind of the highest of high risk, highest of high cost, really keeping them out of the emergency room and hospital. But while we have, so we go through kind of the basic blocking and tackling of how are things going, but it gives us an opportunity to get a patient with diabetes on the phone, and these are the areas that are unknown that need attention, you know, an A1C, and we can verify that those are completed. It kind of gives us an opportunity to walk through with the patient. These are your conditions, and this patient happens to have several, serious chronic conditions. These are your conditions, and are these evidence-based guideline, things that are needed? Have they been completed, or are they still outstanding? And we can kind of walk this patient through the year of managing their care and coordinating their care and being a health coach to them, verified it's completed through the relationship with the patient. So while you've got them on the phone right there, it's a great opportunity to schedule them back for those specific services. And then what do you do from here, Sadie? Go to generate the report and wrap it up?
You can, yes. Up at the top, the green. Yep. Launch report.
So you'll see that the service, while it's executed differently than an annual wellness visit, it's very similar in nature, that it's a structured conversation with the patient, reviewing the compliant requirements to complete that service, but also it generates a visit summary of what went on during that encounter, and also a risk summary of what conversations took place with that patient, and if any areas of risk populated. The care coordinator, if any areas of risk were detected, the care coordinator is then prompted to schedule that patient for a PCP encounter for PCP intervention. I think that takes us to the scheduling tool. So the annual wellness visit portal and the chronic care management portal are very service specific. The gap in care scheduling is not service specific at all. It's very task specific. So it really is about identifying care improvement opportunities within a practice or physician's patient population, and then working with that practice on what their approved criteria is. And candidly, each provider and each practice may have different approved criteria. One may want to focus on, we just hired a new practitioner, so just identify who the obesity and weight loss counseling opportunity patients are, and we really want this nurse practitioner focused on weight loss management. It may be, we just hired a new physician. So go find all patients that have not seen any of our other physicians that are in our patient database but have not engaged any other PCP in 24 months, and try to recruit them in and engage them or re-engage them, reestablish them with our practice under a new PCP that we brought on board because we need their schedule filled. It may be, hey, we're in the fourth quarter of the year and we're in the 42nd percentile in diabetic A1Cs. We know if they're not, having their A1C managed, they're an unmanaged diabetic as a whole. Bring those patients in. Let's focus on our A1Cs, but we'll also focus on our health improvement of our diabetic patient population, which, by the way, is a double-weighted HEDIS measure, so a really important quality metric to get right. And I think this is just a simple snapshot that shows you kind of how this is something our management team would use in managing our scheduling department. We would look at our schedulers. We'd look at how many calls they're making today. We'd look at how many patients they've reached today, how many they've scheduled, and then same thing for the week. How many calls they've made, how many they've reached, and how many they've scheduled. So there's a couple things that can be identified in this tile. You can find a scheduler that is simply not putting out the effort. And you can see, while they're averaging somewhere around, one in the 180s, 190s, 120s, 245. So you can see some people are putting forth a lot of effort, a lot of call volume. You can see there's a scheduler that hit 25 and 57. So it's kind of a great opportunity to go and say, hey, what gives? This one at 57, you can see that they've reached 23 patients and scheduled all 23 of them. So they can say, hey, I've literally been on the phone, engaged with a patient, all day. Even though the call volume isn't there, certainly their scheduling success is. Okay, that makes good sense. And then you can look at, another one that maybe they've reached lots of patients. They reached 23 patients and only scheduled 14. Well, we really want to see them scheduling about 2/3 of the patients that they talk to. So if somebody's, they're around half, then maybe there's an opportunity to review the script that they've got and see if there's some improvements to their scripting, or if they're being compliant with the script that's provided for that practice. Just kind of some management tool, service improvement opportunities there. And then kind of a quality control. We look for patients that are scheduled in under a minute. We look for certain patients that we have algorithms written to detect calls that may need to be listened to or audited, just to confirm, because they are in a pay-for-performance relationship on their scheduling performance, just to confirm that those are indeed quality calls. The scripting's good. They reviewed it. There's a kind of a schedule summary that we like them to go over. Okay, Mr. Frost, I've got you scheduled for 2:30 on Thursday, September 7th for your care management follow-up, and that'll be with Dr. Jones. They're at Eastside Clinic. They're at 107 Main Street, right between the Big Baptist Church and the Dollar General. And then the patient will respond that they've noted that, or do you have something to write this down on, or can you put this in your calendar? And then also we do a scheduling opportunity, which is just kind of glance that if a scheduler comes to the management team and says, hey, I've called through the whole roster and I've scheduled and don't really know where you want me to go next, we have an opportunity right here that kind of is an algorithm of what the schedule, what the roster allows and what the schedule allows. So a practice that has a roster with a ton of opportunity that the practice only gives us, 2 appointments a month, that opportunity score would be very low. A practice that has 1,000 patients eligible for service, and on top of that, the practice is saying, hey, we want 4 patients a day per provider of all 25 of our providers, and we want that yesterday. We're ready for that to rock and roll, and we're not completed with that, then that'll have a high opportunity score. So that's kind of where you get where a team lead can look at this and quickly do scheduling assignments. And then say to use these tools at the bottom. So I'll let you kind of walk through what they are and how you use them.
Sure. We use these tools actually on a daily basis. The user admin is where we're able to add or delete users, meaning schedulers, on any given day. Assignments are where we use this tool in order to make assignments based upon, like Nick was talking about earlier, the opportunity and the schedule opportunity within the clinics, what's needed, how are we tracking that month for that clinic, and that's what really determines where the schedulers are on any given day. We use the scorecards. This is actually something that we do throughout the week. Let me see if I can get one to download so you guys can see it. But we use this throughout the week, and we're able to grade the scheduler based upon their scripting. A lot of these are pulled from that quality queue that Nick was talking about earlier. If they're under a minute, we really want to see if they are scheduling these and they are scripting them correctly, how are they navigating these calls in order to make them more efficient. Each scheduler is given one of these per week. It also helps us to be able to coach them a little bit. What are areas of improvement? Sometimes it just boils down to attitude on the phone. What's their tone? We'll play some really good calls with upbeat personalities so they can see the difference, and then we'll play their own calls back to them so they can hear themselves as well, and that's a real good tool.
Just coaching things. We ask them to smile before every call, things like that, just to set the tone. Go ahead.
Absolutely. Patient lookup, admin uses this. We get clinic concerns sometimes or EMR concerns to where a patient is keyed in and they don't understand, what date and time, things like that. We're able to pull this tool up, and we're able to look the patient up within the roster by date of birth, first name, last name, any identifiers that the clinic can give us. And it's a tool that's used very, very efficiently. Within, I would say, less than a minute, we're able to track down any issues and get them resolved.
So that's a client of ours or a clinic that calls us and says, hey, can you pull a call on, Mary Sue Smith that came into our clinic this morning, said she was there, but she didn't know who called her, didn't know why she was there. She was a little bit frustrated or put out. We just wanted to make sure that the quality of that schedule, just to hear what she was told, because she said something about she was going to lose her insurance if she didn't show up, and that's all she was there for. Somebody called from Medicare, and if I didn't show up, I was going to lose my insurance. And obviously that would be an issue if it was legitimate, and we do get those from time to time. So we built that kind of patient lookup for quick access to be able to, tag into the system, be able to pull a call, listen to the call recording, and always share that call recording back to the practice. And that has been an unbelievable defense mechanism that I'm not trying to throw our shoulder out of socket to pat us on the back, but all of our calls that have been investigated have been very good. And the clinic, after providing 6, 8, 10 of those calls over the term of the relationship, they'll just stop asking. That you build a sense of trust, that they don't worry that you're not appropriately communicating with their patient base, and they'll just say, well, Miss Mary Sue, I'm sorry that it was miscommunicated on the telephone. We're glad you're here today, and you're here for an annual wellness visit, and we'll get you back in just a couple of minutes. Thanks so much for coming in, and just kind of kill them with kindness there at the front desk. Go ahead.
Roster Launcher, that's actually one of the views the schedulers can get, determining what clinic they're assigned to. Each visit type here, so they're able to launch the roster, whichever visit type they're going into, and then from there they're able to sort based upon eligibility. You're going to see the no answers are at the top, eligible are at the top. Once you get later in the roster, you're going to see some that are scheduled, they're not eligible based upon date of birth. Some of them are not eligible based upon insurance, things like that. A lot of our clinics don't want the self-pay schedule, so you'll see a lot of those at the end of these rosters. The schedule admin tool, we utilize this when clinics reach out to us and they want to edit their schedule, meaning they want to add visit slots or they want to take some away. Schedule Builder, we're able to build out the schedules that are approved by the clinic months ahead. Usually we try to get them at least 3 months ahead, just simply for our care management appointments that are scheduled every 3 months for the patients. We want to make sure that the scheduler has the ability to schedule that out 2 to 3 months if necessary. Then we have the actual schedule view. So this is what the scheduler would be able to look at on any given day. They're able to go to their dash and they can see, it's their username. How many do they need in order to hit their target, 125? They show how many they called personally, how many they've reached, and how many they scheduled. Now, I will say throughout the day, admin will usually chime in on our group messenger that we have just to let them know you may be ranked at number 1 or number 2. However, you just need to pick up your calls. We utilize that to keep them on task and somewhat create some competitiveness amongst them. They like scheduling, obviously, because they are in pay for performance, but it also lets them know, hey, even though you've made 100 calls, 3 other schedulers have made over 250. So it kind of shows them where they are as opposed to the other schedulers.
Kind of a real-time scorecard, if you will.
Correct.
So we have a setup document that we placed. Just walks through the basic questions. Who are their primary points of contact, leadership team, and what's their desired for scheduling? What's their system in place? What are they trying to accomplish? So we've found this to be important at the management team because, candidly, when it's laid at the steps of the middle management, we have found the middle management doesn't execute and doesn't won't support to the physicians. I'm trying to find the correct way to articulate this. The middle management won't defend executive management to the physicians of saying, no, this is, through the Affordable Care Act, we're being held accountable financially to perform in these areas, and this is a critical part of our operation. This is something that we got to get right. They're like, oh, the doctors are busy and they're seeing 12 patients a day and they just don't have time for any more. And we really can only do 1 patient a day per provider because they're already so busy. And it's important to be able to go back to a document to ask the CEO or the CFO or the COO, hey, remember when you said that based on, quality metrics or based on financial metrics that you needed the team to perform at this level? Well, we're getting some pushback at the middle management level, and this is what you indicated that you wanted. So this isn't really, quote, unquote, our fight. This is a conversation you guys need to have and finish internally, and then just give us some feedback on specifically what it is that you're trying to accomplish.
That's why I was asking the question. That's why I was asking that question earlier about the pushback.
Yeah.
I was just like, when we were back on the risk assessment, I was just trying to figure out if they thought this was just additional work or if it was, that's what I was referring to earlier.
Well, it's presented to them in a way that it is accountable care, which is not something that we came up with, so don't shoot the messenger. The people who pay the bills are implementing this model called accountable care, which means you're being held accountable for doing things, and they wouldn't hold you accountable for doing things if you were already doing a good job at it. So these are very candidly and very respectfully, these are additional things that need to be done. Now, within that additional expectation, we have a problem because it's not getting done effectively, efficiently now. So here's a solution to that problem. It's called the Care Team Coordinator Business Model, and all of these things can be done under your supervision without you actually having to do them yourself. And I think those are huge value adds to them once they understand it. You're not getting away from this. If you don't do it, you're going to be financially penalized, and you can't afford that. So, these activities need to happen. There's additional revenue stream for them happening, and they can be facilitated in a very user-friendly, patient-friendly, fully compliant operation that you yourself, Mr. or Mrs. Doctor, don't have to do the work. The only thing that we ask is we want to understand how many patients you or your management team want on your schedule on a daily basis, and we simply data mine your patient population for opportunities and then say, hey, where they're not at capacity, whether the doc wants it or the management team wants it, where there's opportunity, we're going to schedule those patients back. So we're not going to ask the docs to work longer hours. We're not going to take them from getting off at 4:30 to getting off at 6:30. That's a bad deal. We're not going to ask them to see more patients a day than their schedule allows. It's just saying they currently have 24 allotted slots on the schedule. They have 3 allotted slots per 8-hour day, 24 allotted slots. And if they only have 14 of those slots filled, then there's 10 slots available today that we can go find diabetics that hadn't been seen in 6 months. Or we can go find a patient that's missing an evidence-based guideline and get them scheduled for, quality of life improvement, quality of care improvement, et cetera, and a revenue-enhancing business model. I honestly, I don't know what's behind these. This is an EMR entry portal, basically, that we validate. Where was I, Cindy?
You have to go back, so go to that second tab, and then that says, we utilize the EMR entry report in order to validate that all of the appointments that have been scheduled are keyed in accurately into their EHR system. Several of the clinics, we do schedule those live, but there are some specific clinics just for, I don't want to say efficiency, mass purposes, because we schedule so many for these clinics. It's just easier to have a data entry support person that
dedicated,
dedicated to keying those in.
So that's kind of ask me how I know. It's important to have a tool that validates that, that we do what we're supposed to from a validation. If we put on 22 patients, we click schedule, we want to make sure that that's validated, that patient was either entered live into the EMR or they're in a queue, that patient needs to be entered into the EMR or practice management system. So it's not one of those things that a patient shows up at a practice and the office manager calls and says, well, we had Mary Sue show up and she didn't know what she was scheduled for, and they weren't on the schedule anywhere, so I don't know what happened. And we have to go back and look and say, oh, yeah, we do see that we scheduled that patient 3 weeks ago, and I'm sorry they didn't get entered in the EMR. So we've kind of put that additional check on there. And then this is a performance report. Okay. So this walks through some, different client services, specifically looking at, kind of what the availability is to schedule, and then kind of how we're trending in months to date for those different services. And then from a billing report, this is kind of what all of our completed services go into a billing report queue. And under that billing report queue, it basically generates an invoice based on the services that were rendered, and it says specifically what services by service type, and then it'll say actual performance dashboard to show how that scheduling has been trending over the months, how many of those were scheduled, how many of those were completed or seen versus canceled, no-shows. So those go back into the eligibility queue. If a patient's canceled, no-show, rescheduled, obviously rescheduled would go into a holding queue. But if they're canceled or no-show, then we want to investigate those to say, is it because the patient didn't want the service, or is it because they just forgot about it and need to be rescheduled, or because the clinic got busy and canceled the patient off and didn't give them any justification? Believe it or not, that happens. So it's kind of one of those things that gives us an opportunity to look at kind of the performance of that particular month to say what happened in that month. We scheduled 200 services. 160 of them were seen. Of the 40 that were not seen, 10 of those were rescheduled, so those kind of go on a holding queue for next month. But these 30 that were no-show and canceled, we want to know why. Is it because they forgot, the patient canceled it because they didn't want it, or the practice canceled it because they were busy and they need to be rescheduled, and just kind of miscommunication. Anything else here under the scheduling portal that would be important?
No.
Good overview there?
It is.
So we go back here to the quality reporting portal, and I will pull up, we can go begin reporting. But before I get into this, let me just launch this piece, because I think this is the most important piece. So kind of understand what's happening in quality reporting. So under quality reporting, this is when the payers, whether it's Blue Cross Blue Shield's Pay for Performance program, whether it's a self-funded employer's Pay for Performance program, or a commercial gain sharing program or a Medicare shared savings program. It doesn't matter what the program is. If the practice elects to participate in a pay-for-performance program, then they are required to do some amount of quality reporting. And, oh, by the way, under Medicare, they don't have the option whether or not to participate anymore. You are by default pushed into a pay-for-performance program now called MACRA. So if you are not already in an advanced payment model, then you are defaulted into MACRA, which is a quality reporting accountable care program. So the most important thing to recognize here is the traditional operation of quality reporting, for air quotes that you can't see. Most practices is that they assign this to a person who sees what they can export out of the EMR if they have that technical capability, and if not, then they're just pulling up charts one at a time, checking boxes and answering questions. Well, that's a very detailed, labor-intensive process, and we have created a process here that automates about 85% of that work. So rather than, Susan at the front desk just trying to, quote-unquote, get done as quickly as possible, it's important to understand getting all the information accurate is the most important thing. Speed is not your friend in this game. Accuracy and optimizing the representation of quality is what you're really trying to accomplish here. So just showing you the easy automation setup. They kind of have some yes/no boxes about their processes internally and then what they allow us to do. And then I will show you this functionality here. Where was I? Right here. And I'll just open a patient. You can see, that we have partially reported on all of these through the process. And then, Eric, is there one that just clicked on metric count? Is it doing some thinking?
I don't believe so. Go scroll on the bottom. Go one of them. I'm not sure. I feel like there was 1 or 6.
Let me click here and see. Let me see. I think for one that was partially completed.
Go back to one of the top ones.
Here, I'll let you do it. So you can see under the and some of these are HEDIS and some of these are ACO metrics, kind of how they title the metric, and then if it's red, it's partially completed, and if it's green, then it's completed. But essentially, you can go here and click on kind of what the partially completed areas are, and then just answer the questions. And through that process, it kind of, again, bumpers on the bowling alley, comes to a completed save progress if it's incomplete, or submit that to CMS, and then that particular patient will then be completed and automatically tees up the next patient. So kind of a user-friendly portal that they can just say whether or not they found the record, whether or not they did the screenings, and if the data is identified, then it's already kind of populated for them, and then all they're really doing is completing those specific metrics. And I think that that kind of philosophically completes the Pop Health Management portal of identifying the risk and scorecarding the providers, a tool that we use internally for the comprehensive risk assessment or the annual wellness visits, which that tool really being the platform that launches either a chronic care management or launches an advanced care plan or launches a physician ancillary revenue portal or behavioral health integration portal. So kind of that being the hub to the spokes on the wheel, if you will, and then, kind of showing you a live chronic care management portal, as well as some proactive scheduling portal that we use for our internal kind of call center operation, and then as well kind of a quality tracking and reporting portal there for them to report back to their pay for performance program. I did want Eric to kind of give a little bit of an overview of the narrative of kind of our programming efforts, which have evolved and transitioned over the years. And then after that, we certainly open up to any specific questions or ideas or areas you'd like to learn more about.
Yeah, so when we started, I don't know if I told you this story when you were here, but we, I answered a Indeed ad for an Excel and Microsoft Access programmer, and kind of when I got on board, I could see that Nick had a lot of things burning and could probably use a web application to put all this stuff together. And so we started doing that in parts, and that's kind of how ITAR 5 came together. Is we started with the scheduling piece to get the in-house operation kind of out of the Excel wrangling that they were doing, and to get a data update process together that was efficient. And then the other thing that he was heavily into at that time was the ACO business, and so we had this lump of Medicare claim line fee that we needed to deal with, and so we developed an application to parse all that data and try to find the meaningful tidbits that Nick was looking for, and so that developed kind of the Pop Health portal. And he also had nurses in the field that were doing all of their wellness visits on paper, and so we took that wellness service and put it into a web application for them to use on the road. And I think we used like Chromebooks and stuff like that to get them so they could have a PC with them. And then, towards the end of that first year that I was with Nick, the ACO had to do quality reporting, so we developed the quality reporting survey. So that was kind of the first four pieces. And then when I came on board full time, we added in CCM, and kind of the V1 that we did was like 4 unconnected pieces of software that had specific purposes. And when Nick brought me on board, we issued a roadmap for V2, and we connected all the pieces. All 5 parts were connected. We added a little bit more of a modern look and feel to our user interface, and we updated the kind of the code base to a modern .NET Core platform, which allowed us to be cross-platform. We could fire it up on any server, Linux or Windows. So if we have to virtualize it multiple times for clients, or if we have to white label it and sell it, or whatever the case may be, we were kind of planning for whatever, and so it could be really put in any spot, and that was kind of a big initiative in V2, and so that's kind of where we sit with the tech.
Yeah, I thought a little more of some technical jargon that's foreign to me might be helpful to you. So I appreciate Eric sharing that. And one piece that kind of came across in his narrative that I don't know if it jumped off the page to you the way that it did us is, again, before every piece was siloed. So the wellness visit was totally separate from the Pop Health management, and the Pop Health and the wellness visit was totally separate from the chronic care management, or now what we're kind of ramping out to the BHI or the ancillary revenue opportunities. The gap in care scheduling was totally separate from the population health management portal, and we kind of rebuilt those in a relationship way that it now truly is circular. So patients that are, through claims data from the payer or clinical data from the EMR that go into kind of a pop health management portal, they walk through the process of laying the foundation of annual wellness visit and then some of the additional services in conjunction with the proactive scheduling and quality reporting, which goes back into changing the population health management scorecards and starting kind of the new year of the annual wellness visit process. Those are not things with a firm start and stop date or a start and completed task. Those things are circular. And there's always diabetics. Every day there are diabetics that, yesterday they were within evidence-based guidelines, and today they have now fallen outside of those evidence-based guidelines, and those things need to be tracked across, multiple portals that have a relationship behind it and not operated in silos. So I think that was a bigger lift than candidly than we had anticipated. And now that that's completed, I think we have an opportunity to spoke out into additional services that we talked about today, as well as potentially, frame this up into, mobile application stuff if desired, or other services as the demand presents itself.
Yeah, I was, we were talking last week, and I was just wondering about what were your thoughts? Now that I got a much clearer understanding of the system and kind of the direction that you guys have been going, what is the opportunity to white label it? I mean, I know we were talking last week a little bit about maybe some other partners coming on or with the ability to use it. Were you wanting to label or limit that, or kind of what were your thoughts?
I have no preference on if the software is a brand or if it's just a tool set that has an ability to be white labeled. I feel like the quote unquote sellability could be much greater if the flexibility is there to white label. If we went into a health system and it became, Mercy Pop Health Management, or it became Baptist Pop Health Management, or if we went into a big ACO and it was white labeled as a product of theirs. It's Caravan, proactive primary care portal, and the PCPs log into this, or the care coordinators log into this, and their patient data is in, and the care coordinators kind of work with this system under the brand of Caravan, which is recognized by their clinic clients. Just speaking on my own behalf, I don't have a preference as far as white label versus not white labeling. I just think it gives you a competitive advantage to have the flexibility to white label.
Yeah, this is a really good system. I just wanted to congratulate you guys on it. I mean, this is awesome. I was thinking back, I think it was around 2005. I told you a little bit, we're working with assisted living on doing a risk management project.
Right.
And, so I've seen a little bit out there, and I've worked, with a couple smaller doctors. So I'm not anywhere an expert. I just kind of understand, I understand a lot about what's going on, but this was really good. I just got me thinking about that, like, man, this is a really awesome tool. And it's just got a lot of value. And, so if you were to white label, Eric, I guess that's a question for you. How is it really scalable? I mean, is there other work that needs to be done in that? Or I was trying to think about from a centralized location, not a decentralized.
Yeah, so I think the idea there would be that we would, instead of Let me put it like this. Like there's a EMR system called Athena, and they are a centralized system in that everybody who logs into Athena is seeing Athena's, they see their logo, they see all of that. The work that has to be done for us is they wouldn't log in and see High Performance Network. So what we would do is that we would virtualize an instance of the code base and just, swap out, all the PIC or HPN labels and replace it with theirs. And that would also allow them to, to pay for any customization that they needed at that point, because it's a totally different code base.
Well, I didn't know if you got, I don't know. I mean, there's a lot of different ways to probably do that. I guess one of the things I'm thinking about, I don't know, I know there's a large value in the data, for research, and I didn't know what your, kind of what the thoughts were because I'm just sitting here thinking this is a lot of good information, and that could be pretty valuable, and I didn't know if you thought about trying to monetize any of that or not.
I can at least try to comment on that. We have definitely thought about it. We've even been approached by participating in it, and I think we have a really unique data set that's a multi-year data set over a large patient population that includes some triangulation of data between claims data from the payer, clinical data from the practice, and the patient feedback or assessment data directly from the patient. So truly kind of triple validating and triangulating data, which is a solid source. I'm shooting from the hip and saying, there's 500,000 people, in the database, or unique patient IDs in the database across a large geography, across, multiple states, and triangulating data. I think there's an enormous value in it, but we don't have the skill set in monetizing on that, data set. And I think there's probably folks that we could engage that would do us a much better service in that. But yes, the conversation has certainly come up. We've explored it, even engaged in some preliminary conversations, and just kind of hadn't fully gone down that path.
Hey, Dan.
Mm-hmm.
One of the thoughts, I'm just throwing this out as just a question. I think there's also it could be problematic on who truly owns the data. All the data is available through maybe Nick and Eric and through the software, but I'm not really sure who would be considered the actual owner of that particular data. Nick, Eric, Dan and I are working on a project with another organization that is actually setting themselves up. It's called the Health Exchange Market, where they're actually trying to aggregate mass quantities of the very data that we're just talking about. And there is some real value to it, but, I just think there'd have to be some really clarification on who's the true owner of the data before we could look at trying to monetize it.
Yeah. And I think legal may have a more advanced opinion, but in kind of reviewing the documentation that we have from a data use agreement, if it's identifiable data that says who the doctor is and who the patient is, then the practice owns it. And if it's de-identified data, just aggregate de-identified data or member ID, blinded data, then we own that data set.
Yeah, because we have some technology that could de-identify it. And so I'm just trying to think about that. But, there just may be some opportunities there. Just kind of throwing that out.
Yeah, you think about the SQL routine, Dan, with with DT?
Yeah. Yeah, I just have to look at it a little bit more and see maybe if there was some kind of, I mean, if it's something you want to look at, but I mean, we have to kind of plug everything together. But I'm just thinking through Colin on that side, and with that technology,
Yeah, and that's all part of this whole process, and that's why I wanted Colin involved in that other conversation we were having, because I think there's some synergy between what Nick is doing with Eric and all the data, plus what Colin's trying to get done.
Well, I was just thinking about also, like, if you white labeled it, and I know it may be a hard sell some places, but even if you brought it on a larger scale, like, if you, like with a MERS or some health system, that data itself would be way more valuable than, or just as it could be pretty valuable. I mean, you're talking millions of dollars just for certain data sets. And if you're holding the data and it's de-identified, I mean, it could be a really additional monitoring.
If the software makes the data sellable, the software doesn't cost anything.
Yeah, and that's what I was thinking. And then use the technology to de-identify it, and then you go to the marketplace and just sell it. I mean, it could be another string. I mean, you still charge for the software, but it would just be an additional thing there.
Correct. Okay. Well, I didn't mean to corrupt the conversation.
I'm just throwing that out there to think about. I'm just kind of thinking about through this. But this is a really good system. I'm kind of excited. I feel like I want to get out there and try to sell one. Just because I think it's pretty good.
Well, we certainly appreciate the feedback. The thoughts that we would have in advancing it may be from a continuing down, or I think there's always an effort that could be made in continuing to modernize the look and feel of different portals. I think you probably saw a little different look and feel from our wellness visit template as opposed to our quality, or portal, I should say, as opposed to our quality reporting portal. Things of that nature are always kind of efforts that need to be modernized. And then you can see our preliminary efforts in, physician ancillary revenue and a behavioral health integration portal that, could be advanced and finished as well. So it's kind of a good status. But there's a ton of, and I'll try to articulate this correctly, there's a ton of logic and learned experiences embedded in the software that we didn't even begin to get to around, managing patient feedback and our status of those patients. If they say, I fell and broke my hip and I'll be in a nursing home for another 6 weeks, or I'm vacationing in Florida and I'm not coming back till September, so call me back, kind of middle or third week of September, and I'd be interested in scheduling. I mean, just lots of things that you can't manage in an intelligent way in a spreadsheet. Just think, hey, I heard that doctor doesn't accept Medicare anymore. Yeah, my neighbor told me that they stopped accepting Medicare, so I hadn't been there in 7 or 8 months because I heard they're not taking Medicare. Well, that's very inaccurate, Ms. Smith. We'd like to get you scheduled for your Medicare annual wellness visit. Just things like that managing patient feedback, even if it's just good feedback for the clinic. Hey, I don't want to go back to that clinic anymore because I was sitting in the exam room and I could hear in the exam room next to me my neighbor, and I could hear all of their medical questions and comments, and I didn't want all my data, all my privacy information shared or overheard just from the exam room over. So I'm not going to that clinic anymore because of this concern. And the practice administrator's going, well, I had no idea that you could hear from one exam room to the next like that, and that's something that we need to address. So just kind of managing the patient feedback in an intelligent way. What needs to go back to the clinic for patient feedback? What's a deceased patient? We don't want to not record that and then have another scheduler call them, and then all of a sudden they get 4 calls a year to schedule their grandfather for an annual wellness visit when it's a deceased patient, and you kind of have to relive that situation time and time again. So just lots of learned experiences in proactively managing a patient population that kind of that logic is embedded in the software that we really didn't have a lot of time to go really deep in, but it's kind of learned experiences. It's things that our schedulers come back and say to us, and after we have a few instances of it, we'll have a huddle and say, is this a one-off deal, or is this something that we experience enough that it needs to be part of our tracking system?
Yeah, you can see that. I've been a part of building. I've been building software since 1997, and I've seen the life cycles of going through this, and I can clearly see, just the time. When did you guys start this, ITAR 5?
2015. So we've been,
So
through
that is
yo-yo cycles of it for 4 years. Yeah,
no, that's good. I'm just really impressed. It's good. It may not, there might be some aesthetic things that you want to change or whatever, but just just kind of looking through that and see that it's really, you guys did a good job.
Well, I want to emphasize, and Ron can back this up. We say all the time that this is not a software sell. When we go into a practice, we don't start with the software and try to wow them with the software. The software is a behind-the-scenes tool to execute the job, and we really built it just as that. This is a tool that we need to accomplish the job. We need, an intelligent wellness visit portal, and we need that portal to identify additional service opportunities, and we need a scheduling portal where we started with hey, let's export all the patients that have been seen in 24 months to a spreadsheet and start calling them and figuring out what they need and managing this thing in spreadsheets and sticky notes. And that was okay for a while until you get a big client that's got lots of locations and lots of providers and lots of complicated schedule parameters of saying, hey, we only want our wellness visits in the South Clinic, in the mornings at 8, 9, and 10 on the dot. But, Dr. Jones out of Northside, he's gone on Wednesdays. So, but he's going to have Dr. Smith in the facility. So we want his wellness visits done on Wednesday afternoons while he's doing nursing home rounds. We'll do the wellness visits there under the supervision of Dr. Smith that's going to be in the facility. And as we started to grow, the complications of keeping up with all the moving parts became very overwhelming, and it wasn't scalable. And the software allowed it to be a much more scalable operation. But you kind of put bumpers on the bowling alley, open the slots that are approved and the visit type that they're approved for, and that makes it much more scalable. That kind of takes the thinking out where a scheduler or a care coordinator cannot execute a non-approved service or cannot schedule in a non-approved slot. And I think some of those learned experiences, ask us how we know that putting those bumpers on the bowling alley, not allowing people to throw gutter balls, is extremely important.
Yeah. So when you look at a practice to, like, when you're engaging them and trying to bring them on as a client, do you, I guess, when you're importing their data and kind of looking at, is that how you do that? You basically take their EMR data, bring it in, and it shows you their opportunity of what you can help them with? Yeah,
so we've got some logic that we've written on assessing the EMR and billing data. And we get that data from different reports in lots of different ways. So it does make the initial gap in care analysis more of a manual process, because we have to, go basically see how that particular EMR exports data and what's retrievable and what's not. So once we can identify what's retrievable, then we can start, running our logic process or our assessment on what's retrievable, and then give them an assessment summary or a revenue opportunity report based on what we had identified. And then when they say, agree that this is a service that we want to proceed with, then there's kind of another step that now we need to go in and kind of build processes for this particular client. On a weekly basis, we're going to update X, and on a monthly basis, we're going to invoice and update the scene report of Y. So to kind of build those technical processes and a schedule that happens on a routinely monthly basis based on each individual client. And then once that's created, I think it makes it a much more user-friendly technical process going forward.
Okay.
Getting into that word that we all like called automation, where there's some logic there, some processes that kind of run, and now we've got some automation built of how we interpret the data and kind of where that data is applied and what's updated. We'll go pull a total patient population every couple months, and we'll identify if there's a new telephone number. If a telephone number is different in the report that we pulled versus the roster that we had, where there's a conflict, which report wins? Well, the new report that we just pulled wins, and it overwrites the old telephone number, and then it changes that patient status to updated phone number. That way, a patient that was in the roster is in a do not call holding pattern because their status was bad telephone number. When that new telephone number is overwritten, then it automatically puts them kind of in a call queue of now we have an updated number on this patient for you to re-engage.
Yeah, so
Dan, what are your other thoughts?
Ron, I don't know if you got any more. I'm just trying to just take it all in right now. It's very clear. I mean, it's kind of like I was just trying to figure out how you do your original analysis, but yeah, I mean, it makes sense now. Kind of do an EMR analysis of pulling the data.
Yeah, Eric, if you got some comments on kind of the analysis process, go ahead and share.
Hey, Dan, so what we do is we have we've actually simplified it here in the last 3 weeks because we found that certain segments of clinics, we're looking for a population that's bigger than X, and if it's smaller than X, we need to go back to them and ask more questions before we start digging into their EMR more. But in general, we basically pull a list of all unique patients and their demographics to include their location and their PCP, and we kind of set that to the side. And then we go in and grab all of their wellness billing codes for the last year. Then we go in and grab to include CCM in the wellness codes and ACP. And then we go in and we grab all the diagnosis codes for the last 5 years. And so all of those are connected by the patient account number. I take the diagnosis codes and the demographics, and I have a template that I drop those into, and then I run it through a Python algorithm, and that gives us the count of patients that fall into one of 10 chronic disease conditions that we are looking for, because we only start with the low-hanging fruit, and if it gets past that in the relationship, then we can always go pull more. And that's what Nick uses to determine the opportunity. So we take the chronic diseases and we do a chronic disease count. So anybody that has 2 or more, we put those in and if they have Medicare, we put those in the CCM category. Then we go check their secondary insurance. And then based on that percentage that is remaining, Nick can see what their CCM opportunity is. Almost all that we've checked have not done any ACP work, and they're low on CCM, and they're low on AWVs, PPVs, and Medicaid. So when I give Nick all those numbers, we basically say how many people are eligible for wellness, how many people are there that have a chronic disease that have not been seen by their PCP in 3 months to the left and 3 months to the right. And
meaning no visit in the last 3 months and no future visit scheduled.
Right.
Yeah.
And then I put that into a report for Nick for a little CEO summary, and that's basically what he built his opportunity analysis off of. So there's basically 3 pulls that we do from the EMR. There's a slight bit of manual work done to connect the 3 spreadsheets together, and then there's an automated diagnosis code analysis algorithm that I wrote, and then I put that into a report. And so that's basically the process from end to end of how we determine opportunity for a clinic.
And what makes that manual is it comes differently from every EMR. The presentation of it is a little bit differently. The column headers or the organization of the data is a little different from one EMR to the next. And it takes a manual process to put that in a, what would be the right word, a commonly identified data set, right?
Right, yeah. So, yeah, each EMR has a different reporting software. There's some that we encounter that are the same, like eClinicalWorks or Athena or Meditech that we see multiple times. But they still have, you still have to pull the queries over and put it into that common. We pull it into our database and put it into common column headers and basically map it to where we want it to go.
So the process is essentially identifying prospect, presenting to prospect. They agree to let us do a free analysis for them. We execute a data use agreement or a business associate agreement. Eric gains access to their system, does the analysis, typically takes, we say give us a week, typically takes, 4 hours in their system, put it into, a meaningful piece of information that we can then go back to the practice and say, here's where we see your greatest opportunities are, and then they agree to a service arrangement, and then there's another kind of manual process of implementing that practice or implementing those services and building recurring automated processes going forward that are much more time efficient, the second, third, and fourth month.
Okay, yeah, it makes sense. So your biggest, really the thing that you're looking for once you've done that and you've started, you were kind of talking about a minute ago, you were just looking at the gap care opportunity and building a process and then trying to automate that. So I guess, you're able to do that by this process here, more or less?
Yes. Once we have the green light from the clinic that they're ready to do the services, at that point we import their data into our system, and I develop the data exchange script. So basically, I develop the reports in their EMR. Each week or month we pull them, and by that time I have developed the EDI or ETL scripts that we need to make that automated process, which is what we have now with 95% of our clients. There's a couple that are still a manual upload, but that's just because they're from dinosaur ages ago. So
yeah,
I think Boston Mountain Kindness is the only one that we have. Yeah,
they're still on mainframe.
No. I mean, they were super early customers, and they've only contracted us for one particular service, and so it doesn't make a whole lot of sense to develop out a big script just for this one thing that needs to be updated eligibility on.
Yeah, no, that makes sense.
And Dan, from just from my perspective, from an end user's side, the clinics themselves, it's really interesting in that they always have a very skewed perception on how well they're doing. They always think that they're doing significantly better than what they all are on actual capture rate of any given service. Wellness visits, they'll tell you that we've got 5,000 Medicare patients. We probably have a 50 or 60% capture rate. And when Eric will do his diagnostics, we'll generate the reports. Instead of having 5,000 patients and a 60% capture rate, they might only have 2,200 patients and a 7% capture rate. And so it's always there's almost without fail, there's all kinds of uncaptured opportunity that the practice just doesn't realize is there because they don't have an easy way to really look at their data.
So when you're saying 7% capture rate, they're only out of 2,200 patients, they'd only be capturing 7% of what what they could. Okay.
Yeah, they may only have 140 or 150 visits done. Is that pretty accurate, Nick, on what we see? Is it's typically single digits in most of the clinics we look at?
Yeah, it's incredibly accurate. I would say, we jokingly say whatever the clinic tells you, just smile and nod and move on until we get the data. But the reality is that's what you have to do. Because if you start back of the napkin math, painting a proposal or building a piece of logic based on what they told you, it is always, and I don't mean most of the time or sometime, I mean it is always wrong, and it's usually wrong by a very healthy margin. I don't know if there's just some sort of a braggadocious inflation that they feel that they all do for some reason, or if it's or if they're that misinformed on how well they're performing or how they think they're performing or what they think their practice looks like. But I would say in almost every case, what the practice tells you their total patient volume is, you can cut it in half and you might be close. And whatever the practice tells you their wellness visit success is, you can cut it in about a third and you might be close. And I still wouldn't bank on those numbers because it's probably less. So kind of our process is whatever the clinic says, great, that's wonderful. We'll be able to tell you how well you're performing, the areas that you're doing really good in, the areas that there may be some opportunity to work together. We just won't jump to any conclusions until we're able to run a report and tell you what the actual findings are, and then you kind of present the findings.
And I guess my final comment on this, Dan, we're looking at, the software and how can we help with the software and maybe make it white labeled and all that other stuff. But it's also a phenomenal tool for us to look at if we're looking at practice acquisitions, because we can go in and we can do the very same analysis on that particular clinic and real quickly identify, is there some true upside potential, and what does that magnitude look like when all the barriers to doing the things are removed because there's new ownership in the clinic. The upside in clinics that agree and are willing to say, yeah, we want to do everything, it's huge potential. We've got a client right now in Iowa, just referencing Pelanick, on how they tied your hands. We could probably be generating several $1 million annually worth of incremental revenue for this particular client, but the person responsible at the local level has basically handcuffed Sadie and Eric and Nick's team and said, well, we only want you doing this and this and this because we think we're doing a really good job on this other stuff. The reality is they're doing a really poor job. And even though they've handcuffed Nick and his team, we're still generating a significant amount of revenue for them, but it's fractional percentage of what it should really be. Pretty accurate, Nick?
Absolutely.
And so I look at the software that they've got. It's certainly a viable commodity that can be used, white labeled. make it available on a service basis, but it is absolutely a game changer if you're using it like we would be using it in clinics that we might acquire or looking to acquire, because it could really validate what is the value of that clinic on a efficient operational basis.
Yeah, it certainly takes the guessing game out of, if our number is 70% of the opportunity. Once we identify the opportunity, you're never going to be able to get 100% fixed. You're always going to have the no-shows. You're always going to have the non-compliant patients that refuse. You're always going to have, some percentage of your patient population that's deceased or moved out of the area, some amount of turnover there. So there's, no perfect model, but to believe with a proven track record that we can get through 70% of the opportunity, you can build a business plan of saying we can take the opportunities that we've identified, we can complete 70% over an annual basis and kind of stage that out as a ramp up over, the first quarter, then to a stable amount of operational success for, the remaining 9 months. And then that's a stable, kind of phase one, proactive primary care services. And then we can start looking at stage two of once we've got operational maturity in stage one, now we're looking at what the additional ancillary revenue opportunities are. Or now we're approaching the fourth quarter of the year, and we're getting ready to be in an open enrollment chapter, and we really want to market to those patients what a preferred, Medicare Advantage payer would look like and offer that at no cost to the patient. And now we're in a value-based contracting stage, which is stage 3 of our business model.
Yeah, well, it's a really good. You got a really good process on this entire thing. So, I think, I'd like to look at this recording again. Maybe go over it, and I've gotten a lot. I mean, I'm getting a good idea, but I wanted to. I mean, I had some questions kind of about your future with this, what you're thinking, and like maybe needs and wants, and because I'm just kind of thinking about it from that angle, but I want to kind of digest some of this and think about it, and maybe come up with some more questions.
Sure.
But
and I'll at least share my thoughts in summary. I will say, as is, in isolation, there's very little that we quote unquote need that the software as is doesn't deliver. We've looked at, is it possible to automate a Geica analysis? Well, there's so many variables in how the data comes the first time from an EMR. It's almost impossible. What about this? What about that? And we've kind of looked at it. And I think we're at a mature spot for our needs as is. But the big opportunities of advancement to me would be, as you alluded, initially on potentially white labeling the software and selling it, software as a service, or looking at, like the Monge opportunity, Ron, and the Caravan ACO, and saying, how could we integrate some of these additional services, whether it's, smoking cessation, or whether it's behavioral health integration, or what these additional services are. And they're going to continue. I mean, Medicare is constantly coming out with, and I'm going to shoot from the hip and say, 2 to 5 new relevant wellness, preventative, proactive care management services, that new codes are coming out, that they're releasing new, kind of compliant operating parameters of what makes this service a compliant billable event. And it's something that they want done because they see value and the cost avoidance of downstream services. If you do this wellness visit, it's preventing downstream emergency room encounters and hospitalizations, those type of value-based services. And that's a trend that is now discovered and going to continue. So as these new services come out, to be able to, program that in a way that fulfills it once demand exists. I would say, if Monge never came through, or another organization never came through and said, we're ready to take on behavioral health integration, would we on our own go down that path? I don't know. Maybe a slight lean towards not, because of the foundation of chronic care management that I think covers, as much, if not more, of the population. However, that's a sellable opportunity if that's something that they're going to sell and implement into their clientele. Other opportunities being, like working with Ron on the physician ancillary revenue, finishing that portal and the logic of those additional services. And we talked about staging those. What are the 3 to 5, kind of foundational ancillary services that we really want to start with? And let's make sure we build the logic and the truth table to that first and implement that in a trackable way, and then we can kind of continue to flesh out the logic for some of the additional ancillary opportunities as we go. Staying very true to our philosophy of value-based, not vulturistic in any way. We want to do what's best for the patient first and foremost, better for the practice, better for the provider, better for the payer of that service, et cetera. So those are the thoughts on kind of from where I sit, where I see the advancements of where it could go. But again, I kind of come back to, as a tool set for what we need today to operate our lines of business, I think it fulfills all of our current needs very well. And I hope you can see that it was not built by, a tech company pushing what the tech company thought the client wanted and missing a lot of those really important detail things behind the scenes of what actually happens during engagements with the patient. It was actually built by, an operator, designed by an operator, that the schedulers would come back and say, hey, there's this, a perfect example is schedulers were coming back and telling us, hey, during these well-child visits, how can we find if that child that we're calling for has other brothers and sisters that might be eligible? Well, there's a linked information on there now. We built a linked information tab that, if they're linked by address or telephone number, it can show other patients that have linked information. And we can say, Ms. Smith, while we're here scheduling, little Susie, we also see, do you happen to have an 11-year-old boy named Johnny or a 13-year-old son? They happen to be eligible as well. So let's find another day, rather than you have to bring them down on 3 separate days. Let's find a day that there's, 3 back-to-back appointments, and we'll just get all your well-child visits done there on the same day. And again, that feedback is given to us in practical operating experiences that the patient, or that our care coordinators give us. And then again, it's one of those things that if our team lead or Sadie or Eric kind of hear the feedback enough, then it goes to a huddle. And and then we look at that from a huddle perspective of saying, what would be the cost? How big of an ask is this? What would be the benefit? And if it's a relative benefit and a relatively simple ask, we can stand lots of those features up very quickly. And I think that's what you're looking at, is a system that has lots of logic and features and learned experiences that when we look at other pieces, they're just a pop health portal, or they're just a wellness visit template, or they're just a quality reporting tool. We haven't found any of the proactive scheduling portal tools out there. But again, they're only those pieces of the puzzle in isolation and not the continuum.
Yeah. And Nick, I think that's what makes your software, I think it's what makes it a special piece of the, technology, in that it is truly aggregating all the things that are necessary to systemically do what needs to be done on wellness, preventive, getting the patients identified, bringing them in, et cetera. Dan, Nick mentioned earlier about Caravan ACO, their accountable care organization. They're probably the top ACO in the nation. they do a really good job on identifying patients who need these very services that we're identifying: wellness visits, advanced care planning, chronic care management, et cetera. And even as the top performing accountable care organization in the nation, which charges their membership what kind of dues annually, hundreds of thousands of dollars that these hospitals pay into to participate with this Caravan ACO. And yet, even though they're the best in the business, all they do is provide a list, but they don't have that scheduling component. And we've been told internally that they're only getting like 11% capture rate, whereas NICS clinics are getting 70, 80, 90% capture rate, and they're not having to have their members pay this big initiation fee and ongoing annual due. So someone like Caravan would be they will eventually come to the table or the realization that simply identifying the patients is not good enough. We have to make it easy to actually schedule those patients. And I think that's what PIC Software does very well.
Mm-hmm.
So there's lots of software out there from a highest of high level that show the problem areas. Very few solve the problem areas, and even less to none solve the problem areas in all the different ways that we do. Some solve one or two of the problems, but again, not the continuum. They're not the Pop Health Management Portal integrated with the proactive services of wellness visit, advanced care plan, chronic care management, considerations of BHI and ancillary revenue, along with the proactive scheduling portal and the quality reporting portal. There are pieces of that out there, but not in continuum. And I think that's what we're starting to hear back from sophisticated organizations like Caravan. As Ron alluded, they're one of the largest, most sophisticated, ACO clinic aggregating service providers out there. They're saying, hey, Monj, I think what you're doing is really slick, but you're one piece of the puzzle. You need to put it all together under one platform and come back to us, and that's something we'd be extremely interested in. And that's when they engaged us and said, hey, you guys are the platform. We're just one more piece on top of what you've already got. Would you show us what that might look like to build that one more piece on there and give me something to go back to this very large opportunity?
Nick, I'm just thinking out loud right now relative to what we currently have the capability of doing. What about HCC coding and somehow being able to automate the capture of that particular critical component? Is that something viable that we would want to figure out? Is there a way that we could incorporate that into your existing stuff?
I think it's more than something viable that we'd want to figure out. Fundamentally, it's already there. Is it executed and done correctly by the clinics? No. But through every one of the check boxes of the wellness visit of identified reported conditions, those reported conditions correlate to HCC codes, and we have that table. And we can put that on the billing report for the practices that want to do that to say this is the service that was provided. It was a GO438. The service description is an initial Medicare annual wellness visit. The correlating HCC codes are 270.1 and 119.2 that correlates to diabetes and congestive heart failure, and the billing code is X and the date of service is Y, to make sure that they get all the important billing criteria of the annual wellness visit program in there. I mean, it's from where we currently are to being able to do that is a put it on their request, and it's already there. I mean, we've already got that relational database table in our software.
Yeah, so we're not currently providing that to them, but that's something that would be very easy to do, is what you're saying, if I understood you correctly?
That's correct. We've discussed it with some practices, and they have not elected to engage that. They don't understand the importance of HCC coding, which is why they're not doing a good job with it. It's just additional work to their billing department as they perceive it. But it is a huge strategic competitive advantage if they understand it, and they just don't.
And Dan, just FYI, the HCC coding is probably the single most important component on negotiating the Medicare Advantage value-based contracts. If you do not have accurate reflection of the true risk, you're not going to get maximum value out of that contract. And so we are talking about just that one little additional thing that Nick can make available is potentially worth millions of dollars on an annual basis through value-based contract payments that are enhanced.
Absolutely.
So a lot to digest, Dan.
Yeah. Well, yeah, I would, yeah, if I can, I mean, if you can get the recording of this, if I can just maybe watch it one more time here in the next couple of days. This is really good. So I just want to kind of digest it, but I definitely will have a few more questions, and then
absolutely,
and just see the best way for me to help and try to put together a plan or something, and then see what's possible here. And then, like I said,
absolutely.
we have some other technology that there may be some stuff that you could use. Anyway, no, this really
collaborative opportunities, right?
Yeah, and then along with Ron's other connection there, might be some pretty good some opportunities there.
Well, I think we fundamentally accomplished the goal that we set out to today. Let's take a couple hours.
Mm-hmm.
Let's do a high-level overview, again, of kind of the service model and the philosophy of the tool set that we've built. Eric kind of told you the narrative of we started with these asks and individual pieces and then came back and said, man, there's too many moving parts. We really need them relational and integrated into one. So that was kind of a big lift. And then we started putting a facelift on the different portals that matter most, if you will, or the most utilized portals. Started coming back and kind of putting a facelift on some of those. Certainly always areas for improvement in all of that. But there's a lot of, I just can't emphasize enough, there's a lot of learned experiences. There's logic that we have forgotten that we put in it and why, that if you started over from scratch would hit you like a Mack truck of, we forgot all about this. Well, it's automatically in our software that correlates patients this way or prioritize patients that way or puts them in a do not call based on, some relationship that the management teams requested or just different pieces of learned processes that we think is so fundamentally important to, every implementation is an improved operation. But with that, again, I think we covered our fundamental task at hand is just to review it, go over, kind of high-level overview, dig a little deeper into some of the specific pieces, answer the questions that came immediately, and then let you kind of marinate on that and think through it, and we can have a follow-up conversation of what additional ideas and feedback come to you after a second review.
Yeah, that sounds good.
And Dan, I was just say short term, if you have any questions, you and I can sit down. I'm by no means at all an expert in the technology, but from a theoretical standpoint on why we do certain things or why they do things, I can certainly help answer any questions if you and I want to sit down together reviewing it sometime.
Okay. Yeah, no, that sounds good. Yeah, I think definitely let's do a follow-up here. And I think it'd be a good idea. Let me go over this, digest it. Let me watch this again, and then let's just, I don't know, here in the next couple of days, let's try to get back together and at least schedule a time to go back through this, or just kind of maybe look at it, and I'll have some other questions and things.
Absolutely. Sounds good. Well, I
Okay.
certainly appreciate your time, and look forward to your feedback after you've been able to think it through and got some thoughts or further questions.
Okay. Well, thank you so much for your time, everybody. Eric, Sadie, Nick.